Hello, everyone. I'm Pinar Givanch, and welcome to What's Wrong with the Podcast. Today, we have the absolute pleasure of speaking with Dr. Alex Adams, who is a professor at School of Interactive Computing at Georgia Tech University. Alex's research aims to improve the current healthcare system by making it more accessible to everyone. Historically underrepresented rural and low-income communities have faced inequalities and disparities when new health technologies are introduced, including issues such as accessibility, cost, and bias. Alex seeks to tackle these issues by prioritizing equity when creating new health technologies. As the director of Uncommon Sense Labs, Alex uses sensing, signal processing, and fabrication techniques to develop, deploy, and assess multi-modal sensing systems. He is dedicated to addressing the needs of overlooked populations and expanding access to quality care through continuous monitoring and mobile diagnostic tools. Enjoy our conversation. Hello, everyone. Welcome to our podcast. Today, we have the absolute pleasure of speaking with Alex Adams. Alex is an assistant professor at Georgia Institute of Technology. Alex, welcome.
Thanks, Pinar. It's nice to be here.
We're really excited about this conversation as I already had a bit of a preview of the things that you're working on, so I'm so excited for our audience. So please tell us a bit about yourself, your background, and how you came to where you are today.
My lab here at Georgia Tech is housed in the School of Interactive Computing. It's also part of the Institute for Robotics and Biomedical Engineering. So we focus on designing medical devices and health technologies with equity as a principle in design. Our goal is to fill gaps in the healthcare system where people have been overlooked or even areas have been overlooked, things like that. Um, my path to get here was a long one. I did my first career as a musician. Went to North Carolina School of the Arts where I studied classical guitar. Um, Meanwhile, I also started a recording studio and a portable recording business. After that, I went to Atlanta, actually, where I'm just happened to be back again. I worked in music industry for several years, mostly on the recording arts and live performance side of things. And I got fascinated with how I could see my guitar string show up on a computer screen, how the electronics that I would plug into could alter the sound, how microphones worked. So I started to look more into that and decided to go back to school to, at the time, get a degree in computer science and engineering focused on and trying to go back and to the music industry from the technology perspective, actually creating music software and hardware. While I was there, a HDI group led by Professor Sling Latulip, I was at UNC Charlotte this time. She reached out to me because of my background and thought it would be interesting to have that perspective on some of their work. And at the time, I was looking at input mechanisms for controlling their students were looking at drawing interfaces. How do you use multiple hands on a computer? And I thought, well, this music would be a great application. So it would be nice to have your perspective and get you in there. Well, that kind of took off, and I just really enjoyed being in the lab. I didn't come from a family of academics, so I didn't actually know what the academic path was. My family were blue collar working class people. We I when they told me I needed to do a PhD, the Celine, she was like, you should do a PhD. I was like, how much does that cost? What does that mean? Um, because it's just not something I ever considered or knew why people did it. I didn't even know you had to do it to be a professor, honestly. It's completely out of my league. Celine actually really took me under her wing and took me to conferences and had me working on lots of projects. And I basically lived in that lab for over a year. Halfway through it, another professor came in, Kai Trong, who's now at University of Toronto. And and I also worked with him, and that got me more into accessibility and health tech. And through a mutual friend, I was connected to Tanzim Chowdhury, who would eventually be my PhD advisor. she was looking into building a microphone to listen to the human body. So this kind of combined my interests. So after that, I was kind of hooked into health, just due to the impact factor that you got, and also the challenge. Some people may think it's like more of a curse than a blessing, but just the endless amount of problems that come up when you're dealing with the human body are just fascinating and frustrating simultaneously. So that led me off into my PhD. I was at Cornell, um, then went to Cornell Tech for a couple of years in New York City. Was a research scientist there, working for the Precision Behavioral Health Initiative, I think that's what it's called. And yeah, then faculty time came to search for faculty positions. My wife is an actress, so I applied to positions basically where she could also work, which is on the East Coast where our families are, is in New York and Atlanta. And Atlanta's, of course, Georgia Tech is one of the bigger schools in computing and engineering internationally. So that was a no-brainer, and fortunately, it worked out. So I've been here this is my third year here. Just actually now completing my lab. We have a big group of people working on a diverse set of problems. Being in a sort of cross-seated in these institutes at Georgia Tech, have a range of students from biomedical engineering, mechanical engineering, up to human computer interaction and human centered interaction on the more qualitative side. So can cover a large basis of problems.
It's such a fascinating background. I think it's always like great for current like students to also hear about these backgrounds, as there's always this like pressure or assumption that we all have these like very linear career paths. And no, not necessarily. Like, guess what? Music knowledge or education is also very helpful in health. So, and I love it. And it's complete the opposite of mine, whereas like my family is purely academics and I'm the first entrepreneur. So it's like I didn't know like how do you go about doing a business? Um, but yeah, I love that as a very self-growth and learning opportunity. Um, so kind of like cue us into us themselves into the topic. Obviously, when we talk about health care, health tech in United States, we have no shortage of problems and issues. I would love to discuss a little bit like underlying reasons of why we see these. Obviously, there are so many systemic issues, but what have you seen in the space that kind of enabled you to also enter in exploring solutions or interventions in that space as well?
Yeah, there's a variety of different issues that have developed over the years and kind of just gone unnoticed as well for a very long time, or unacknowledged, maybe is a better way to put it. So some of the bigger things is systemic issues, of course, which are just hard and long to get past, right? It takes full infrastructural change, right? You know, lucky to see much progress in that area in our lifetimes, even.
Yeah.
Um, and then there's also just been a general shift in society towards what we go to the doctor for, where doctors'
Mm,
offices are located, right? There are no longer so many like town doctors that have lots of resources. It's mostly all moved to larger corporations.
yeah.
Um, hospital um, groups are buying up most of the regional hospitals, and those still all seem to be clustered around, a small portion of the US as far as having a sort of advanced care. Things like NICU centers and stuff like that. It's not something you see at every hospital or every part of the world or US even. Um, so there's big gaps geographically, which is one of the bigger problems actually. And when there's what happens is then people that don't live in big cities and stuff like that, typically there's sort of groupings within that too. You say you have a small city that's going to have a large gap in socioeconomic classes, right? And then you'll see things like food deserts that attribute to poor health, living by sort of polluted areas, also contributing to chronic diseases like asthma, things like that. Um, and then there's also then specialists that are far away because you don't have insurance, you don't have money, you live in bad health conditions, your health is worse than someone with money. So socioeconomic, of course, is one of the just biggest disparities there is.
Yeah.
Uh, And that's one of the harder ones to also sort of bargain, right? Um, so one thing that came out of the pandemic that is actually quite good is the advance in telehealth. So telehealth has at least got people FaceTime with medical providers that are, say, not very mobile, that do not have a car to transport them, say they're aging in place at home, they're not safe to drive, various other things. Also, just reducing exposure for certain things, right? So if you think of a hospital, or sorry, waiting room at a doctor's office or a hospital, it's basically a place to go get sick if you're not already. So if you have a comorbid disease,
Yeah.
then it can be very risky. So we have this new telehealth infrastructure that's really quite ubiquitous. It's probably more common now than an in-person doctor's visit for standard care. What this does, though, is it gives infrastructure for us to add in more checkups, more continuous measurement. Because I think from the get-go, one of our, even before I actually identified what I was doing as working in health equity or to enable health equity, I should say, not a equity scholar by any means, but working in that to enable that field. So I was always looking at continuous monitoring. How do we get more data over time so we can start looking at causality? We can start looking at change. You know, if you think of point of care, it's like, all right, I go to the doctor. What's my health at that exact point of measurement? Right. So think of that if you were looking at your fitness. If you just had a fitness check once a day for, say, all right, so I just took 4 steps, or my heart rate right now is 67.
Yeah.
Right. So it's means nothing. Um, so things like that are less persistent, like pain, aches, swelling, stuff like that, might have completely subsided by the time you go to a point of care check.
Yeah.
So how do we know when that happened? What caused that to happen? Things like asthma, which are can be triggered by viruses and also pollutants. Allergens are a big one. So how do we know what the trigger was? You have to all of a sudden rely on self-report and self-documentation, which is very difficult. So having some means to actually monitor people more frequently and remotely just really fills a lot of the gaps in our current healthcare system. And then we try to do that all from low-cost systems, mostly leveraging smartphones that have not only built-in sensing, but also just the built-in network and computation that we didn't have previously, right? So now you don't necessarily need to have the internet. You can have the mobile phone plan. Um, we've got a ton of computation in these things. We also have a lot of really high quality sensors that might not be the only thing we need, but we can use those to
Yeah.
help understand different components of measurement. So that's been kind of one of the biggest areas I've looked at is that remote diagnostics and continuous care.
Yeah, but it's such a good example of, meeting people where they're at, right? Like obviously systemic change, sure, right? If we want to tell like how do we make things better, let's talk about like the system, the healthcare system, and let's change it, and then jobs market, right? It's such a complex thing to address. But how do we empower people knowing their current day to day, like what feels natural to them, and how do we tap into that? So that we can actually provide some of the health monitoring that is at the present very expensive or even inconvenient in so many ways, or not even feasible if you're working a full-time job. How do you just, and have kids, like how do you just go and get a checkup on a regular basis at a doctor? Like maybe you're not able to take off from work. Um, and if, also just economically, like maybe it's not feasible, or if we're looking at even in more tricky situations with maybe more marginalized communities, like maybe undocumented individuals, do they even feel comfortable going in for a checkup at all? I think that is a really great way, like understanding humans and communities, how they work and how do we tap into that. And whether I like it or not, we like it or not, smartphones are, we're very dependent on them now. It's part of our lives. I think you were sharing the other day, what is the percentage of people who have smartphones?
Something around 93 to 96% in the US, I believe.
It's
It's a
insane.
yeah, it's an incredibly high number. sure. And you've probably seen this being in New York City. I remember seeing this frequently is, homeless people sitting up to a plug to charge their smartphones. I
Yeah.
mean,
Yeah,
it's not very uncommon at a subway station to see someone sort of hoarding the outlets if they
exactly.
find it.
Exactly.
Which
And this is
is
an
fantastic.
area. Oh, sorry, go ahead.
I was just say it's fantastic. I mean, there's more than just health that sort of connectivity gives people, right? It's like, well, just homelessness and poverty does not mean that you don't have other people that are missing you or you care about or want to
Yeah,
know how you're doing, right? So
exactly.
there's so many levels that the pervasiveness of smartphones is beneficial, and there's a lot wrong with it too. Don't get me wrong.
Yeah, I mean, that's the thing though. Like, obviously, every virtue comes with its vice, but at the same
Yeah.
time, if technology is gonna like evolve very fast and eventually also get cheaper, how do we take advantage of that? And this is a really interesting area in how you actually take it to your advantage or, to address a problem. So if this is now basically, let's just say, almost entire population has smartphones. These smartphones are getting smarter, more capable, right? The cameras on them are getting, really, really qualified. What does the future look like to you when we're really able to tap into these phones to do a lot of self-monitoring, and maybe not even only diagnostics, but maybe some solutioning? Like what does maybe a future 20 years from now? Maybe 20 is too hard to estimate with everything happening with AI. Maybe we just have robots at home. I don't even know anymore. But let's say a couple years from now, near future, um, how do you see things shifting? I think the pandemic is a really interesting kind of anchor, to what you were saying, like how telehealth actually grew, right? It was almost a catalyst for that. And to your point, maybe one of the silver linings. So what does the near future then look like with that?
Yeah, so there's a couple of things, and cameras are a great point of stuff that we will never be satisfied with having a better picture, right? More megapixels means better all the time. And it's funny because that's one of the things that we kind of count on getting better. So a lot of the stuff that we do is based on sound and light, electromagnetic waves, not necessarily just light as a basic measure, but looking at the spectrum or looking at microscopic images and stuff of that nature. So the better these cameras get, existing technology just rides that wave if we're leveraging the camera on a smartphone. And that's part of what we do, knowing that media is going to be a driving force for technology, as it always is. Um, and there will be additional sensing that will be implemented in smartphones throughout and other means of connectivity. So I think one thing that you're going to see grow over the next, 10 to 20 years is better processing always, right? That's one thing that people will never stop doing is trying to get smaller transistors and more packed, energy efficient and processing power. Um, More sensors to some degree, and then but better at the ones that there are, and that will give us better measurement, of course, and the ability to do more processing off of more larger models, off of larger models in the cloud network, right? And our connectivity speeds up as we get better, 5G to 6G to whatever. So you're going to see just overall improvements, but also overall connectivity improvements. So you'll start seeing little featurettes pop up where it's not just phones, it's, the devices embedded into the world around us. So there's a huge takeoff on things like smart speakers and smart TVs and things like that. They're getting better at meshing these together and creating these little mesh networks and allowing you to pop in and tap into certain parts of it. There's a lot of, you know, they're not the most reliable things always now, right? You'll have stuff drop off here and there. There's problems, but that's some area that people are really working on. And you can see even things like if I want to share my contacts, I can bump phones now, right?
Yeah, yeah.
So
I love
simple
it.
little like that, yeah. And being able to scan, right? I can scan a credit card on my phone now, right? We have
Yeah.
NFCs and we do RFID stuff, right? And so this means we can also look at how can we leverage RFIDs for a quick local sensor that might be powerless and just be recording, right? Based on the actual power from the phone. Uh, Inductive charging, they're looking at doing beam forming with that to make it non-contact completely. So you're going to see a lot of sort of devices being one word that people love using right now is democratized. So, so there'll be a lot
Yeah.
of that. It's a good word for that use case. I really hate buzzwords, but so you'll see a lot of democratization of devices. You're going to also see a lot of meshing, which leaves room to get different types of information from different points. The idea of the smart home is a slow burn, as far as like a full on smart home, right? That means you need to build it from the ground up. It's going to be high price.
Yeah.
It's going to be basically home goes down, maybe a smart home goes up, maybe not, depends on the cost.
Yeah.
So then there's companies like Amazon is doing a lot, and how do we get sort of patches, new outlets that we can slap on top, new light bulbs. And the thing is, all these different things can be used for different types of measurement to some degree, right? Or some understanding of activity. And it might not be just pure vital sign measurements. So, say some fields like child safety, aging in place, just knowing if someone gets out of bed or is in the
Yeah.
house, super important. Um, so, if you have a smart lamp right on the side of the bed, then there you go, right? You have
Yeah.
something as simple as that. Um, the single point sensing is a term we use for things like smart speakers that have, some sort of motion sensor, they have acoustic
Mm.
sensors, like that. You'll see more sensing added to those. More types of sensors to do more gesture recognition is a big thing that people are looking at. There'll probably be some more camera-based stuff. People love and hate cameras. They hate when they're in stuff that might be watching them, but they love to have them stuff.
Yeah, exactly.
So
We're
I think
paranoid of Alexa when it's in every
yeah,
room. Yeah.
there's gonna be an uptick in purchases of duct tape to cover the cameras, but more cameras embedded into stuff. So some good stock advice right there. Tape tape's gonna
Invest in tape.
yeah, invest in tape. Taping cameras. Um, so yeah, I think you're going to see a lot of that. We are looking as much as possible from the technology standpoint and the diagnostics and biomedical engineering standpoint. How do we leverage as much as infrastructure for as much as possible?
Mm.
So cameras are embedded everywhere. That's a big one. Microphones as well. So things like you'll see more stuff in understanding aspects of human speech, cough detection. Um, uh, Camera-based pulse rate measurements. It's called RPPG. A lot of different stuff like that, and then technology around cameras to help deal with things like color balance, lighting, inherent issues with it. Are some big things. So really, I think you're gonna see less stuff on people than we really think about for a while. It's until we get stuff like band-aids and
Mm.
stuff like that settled. And that's, I think, more on your 30 to 40 year timeline. Um,
Mm.
as far as getting into human hands, there's a bunch of stuff being researched now, but the steps to seeing that out in commercial commodity devices are much further than single point sensing and mesh networks already out there. So I
Cool.
think you'll see that getting refined over the next decade.
But love your approach because, a lot of people who are excited about these changes are also um, very like, tech is the savior of all, like very tech solutionist and super champions. Like when you talk to them, you feel like you're in a Star Wars movie. Just like, yeah, it's gonna be so cool. But then how your approach is it's very cautionary optimism. Like you are also aware of all the biases, stigmas, societal readiness in some of these things that are coming. And your work kind of like approach addresses those as well. So, do you want to give an example in, maybe one of your projects and talk about that side a little bit?
Yeah, yeah. I mean, I'm all for moonshot research, and I've got a project I'm working on as a contractor through ARPA-H right now on implantable cancer treatments, right? So that's like far side of that, right? We're helping with, at the source of the problem. Then we have other work where we're turning cell phones into microscopes, and doing so for like $10. And these are not just like you could buy some of these on Amazon where you can like look at a bug's wings or something. They're
Yeah.
actually visualized blood cells. So they're going down to like
Yeah.
2 micro images, right? So
Wow.
we could see blood cells, which means we can also see when they're not looking right. And we can hopefully soon get to where we're really doing some counting, and eventually to a complete blood count, which being able to do that on an instance would be huge. Especially these are all done without sample prep as well. So we've gotten rid of centrifuges, any refrigeration, mailing
Yeah.
samples out, and then a flow cytometer, which is essentially what we're trying to replace. Those are start around 100K and go up to 500,000 or so. Um, so if we can have something like this that could also be used for even say triage within FEMA in emergency situations, deployed with troops out and for combat, field medicine, um, and then or just at the local doctor's office, right?
Yeah.
Um, and then we started doing this other great thing that we love doing right now is creating different types of databases. So now we
Mhm.
have a database that we can create of images of blood cells that we can label and use all of this, big model AI work on. And essentially the work can continue in the background after we right now we're looking at red blood cell counts and urine for hematuria, right? So, but that same data can be used and processed and worked on again and again and again, looking at say, what else do we see in there? All right, can we count this better? Can we do individual cell count versus regression based on flow, right? So there's a bunch of different types of things that can be advanced on with the data sets itself. And incorporating new types of real world data, I guess you'd say, is a big thing that we're doing as part of our contribution. Um,
Yeah, and how the good data, maybe, I think,
yeah,
yeah, and how we collect that data and approach around that. And I know like some of your work also really just like acknowledges our biological differences in our human population as well, and not necessarily skewing all the studies in one direction, which historically has been the case. I think there's a term for it, no, in like psychology, it's called weird people. Like apparently 90% of psychology studies are based on like Western white individuals, and it stands for white. I need to like Google it now because
like,
then somebody's
yeah,
gonna try to like fact check this. Um,
yeah,
uh, like it's a whole term because um what is it? Oh, Western, educated, industrialized, rich, and democratic. That's
okay.
that's what we are saying. I knew you love acronyms. This is perfect for you.
So basically, Western college graduates that make some money. Um, that are just
Exactly.
they're just fine. Yeah, different
Exactly
types
it.
of problems than most of the world, right?
Yeah.
Yeah,
Yeah.
yeah. I think part of our work it's looking at uh, how do we get care to people for certain diseases and stuff. And sometimes it's about the tool, right? Can we take this tool and can we, drop the a couple orders of magnitude in cost? But often it almost always starts with a specific problem space. Like the microscopy stuff was looking at kidney disease, was where we were kind of looking to solve problems. And I met with a nephrologist, talked to him about sort of what all the standards of care are, what's the gold standard, what are the sort of measurements, the metrics to look after, and what is the need for more information. It's all, here's what we have, and yes, 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 more information. They're even doing like at-home blood kits they send people home with now just to get more information, especially in lupus nephritis, I think was one of the big areas where they need
Hmm.
or continuous updates. Um, so yeah, it's looking at that problem space that has got a large gap within itself. So kidney disease, I think Black American population is responsible for or has 33% of all kidney disease in the US, and they are only
Wow.
13 population, right? So just proportionally, it's insane. It's 4 times white Americans. Um, and there's a lot of reasons for that. Most of it will be other socioeconomic disparities, food, diet, lots of basic other health disparities that lead to kidney disease are what's causing that disproportionate thing. So it's worth looking at the disease specifically, and then if we make a tool that we can apply elsewhere, we do.
Yeah.
It goes for larger groups like women, right? So how much home tech do we have that is specific for women's health? Is not a lot, right? The body composition of a woman is very different than that of a man. Um, so if you don't have adequate tests done evenly distributed across both sex and in case of things like optics and some other stuff across sort of skin tone as well, then you end up with these biases that will cause some sort of health disparity later down the road. And that's something that happened with pulse oximetry that was initially exposed or discovered, a couple of decades ago. But with the pandemic, that was another thing that kind of came out. It hit the spotlight because the amount of respiratory illness that we had. Um, and then in women's health, I have a 2-year-old son, and as my wife was going through pregnancy and, after birth, and seeing all these little low-hanging fruits, essentially, that there was nothing to help with, in particular, like just understanding the general health of the fetus while you're,
Yeah.
right, we had a couple of miscarriages beforehand, nothing like full term or anything like that, but still it was very cautious. Like we were very nervous the first couple of
Yeah.
months. And all we want to do is say, is this child okay? And that's led us to do a lot of work in that area of sort of maternal health afterwards. So looking at activity recognition for fetal health with a smartphone is something we're very interested in, and we're starting to get off the ground. Then also postpartum, one thing that one of my students and I are starting to investigate is how do we help people with posture correction, and specifically pregnant women, because this is, I would say without a doubt, the largest physiological change you'll have in a short period of time, right? All of a sudden you have a
Yeah.
small person growing on.
Yeah.
then
And
you
your
can't.
intestines are next to your lungs. And
Exactly. And so this makes you shift your body around a lot. And then you actually, you have the baby, and then you're carrying a baby a lot. And there tends to be some displacement that happens then too. So a lot of back pain, a lot of posture problems. There's not very much in the US for postpartum care as far as insurance and payers go. I think it's like two general health visits afterwards, which is is absurd.
I
And
know.
this is something that I was talking to some people about recently. Is how do we get maybe sort of a bundle package for care and within pregnancy, as it happens in renal disease and in orthopedics, right? Your insurance pays out for the entire scope of care as one payment, which means for physical therapy afterwards, and for dialysis and dialysis fluids afterwards, and kidney disease, right? So why don't we have that for postpartum care? Postpartum depression, huge. There's a lot of cardiac problems that come up postpartum. Could easily be monitored with the, just send them home with a wearable or ambulatory Polar H10 ECG, right? You don't even need to go to the doctor that much if you have continuous monitoring. And then a variety of other things like cesarean section, right? If you are essentially cutting the entire abdomen open and you're just like, all right, go home,
Yeah.
sleep it off, and then you're
Yeah.
fine. So
Yeah. And speaking of a moment of need, right? Like when else, like in your life, you're never like you're the most short in time that you ever were. You're so tired, like going to a doctor, like you've been going to so like doctors so many times throughout your pregnancy anyway. Like you would rather, and already you're like worried about 500 things as a new mom. You want everything on your phone if possible. I think that is definitely it's a huge, huge opportunity and such an underserved area too. I think a lot of things in women's health anyway, and in design, we have this term like just make it in pink. Is basically how design for women has been like addressed in history. Not necessarily ergonomics or anything, acknowledging like the bodily differences. So I love
yeah,
hearing anything in this space that would, elevate that conversation in women's health. Um, I have a question, and I don't know if it's a controversial one, but we'll see. So, speaking of sensors and the potential of sensors inside our bodies,
Mhm.
s- so what do you think? What is your stance on this? Like politically, no, but like seriously, I could see, and we've seen this in like the disability space, like the potentials that it can have. Or else, just speaking of health monitoring, right? Like it can have massive potentials. But what do
Yeah.
you think about having microchips in our bodies?
I think it all depends on what they're for. It's cost benefit ratio, right?
Mm.
I don't think I need a cell phone implanted into my head by instance. So if you're out of some of these really futuristic things, I think I'm fine holding the phone or, earbuds. Um, there's going to be some stuff that comes out that's going to basically stand the test of what is accepted and adopted by the population. So I'm sure low-hanging fruits would be like RFIDs for like credit cards and things like that. That'd be an easy one, right? We could do that as an implantable, no problem, or have a wallet. So, and actually now it's on our cell phones. So then if we have our head cell phone, I guess we can just move on with it. But no, I think for very specific things, implantables could be very useful. I think there's other routes to look at first. There's sort of microneedles are great technology that I think are still being developed on. I think they're going to go a lot further before we get to sort of any exhaustion on those. They're also, slightly invasive, like by microly invasive, I guess you would say. Um, but the amount of detail we can get on that and seeing them being used in a more commodity setting, like understanding your dietary needs, stuff like that, is starting to come out. Um, Full implantables to treat a disease, to pacemakers, right? Things like that. There's also high risk with that. I'm pretty sure that every medical procedural show has done some episode where a pacemaker gets hacked or something like that.
Yeah.
Um, so, so is that possible? Probably. Is it probable? Absolutely not. Um, so I would say we should always proceed with caution, but also just make sure that we are offering more benefit than the cost of having it. Um, if it's implantable, it's harder to shut off if we don't want it.
Yeah.
There's things we can do in health besides implants for most diseases, or I should say for a lot of the diseases we would look at doing an implantable for. So there's also a field called digestibles, which is
Mm.
less public, but basically just pills with, say, cameras for looking at motility, pH sensors, temperature
Oh.
sensors.
Mm.
It's much more, well, pun intended, digestible to have a you take. That's
Yeah.
an implant, right? So I think that we should do this incrementally for sure, but also the research needs to happen looking 20, 30 years out as opposed to, what'll hit the market sooner. Um, yeah, if you ask me, it takes me a while to adopt a new technology, even though I like building new technologies, right? So if I want to
Mm.
integrate it into my daily life, it it takes me a minute to see what the true value of it is. I think that's true
Yeah.
for I think that's true for a lot of people that don't realize that they just get excited by it and then they stop using it.
Yeah. Yeah. Yeah.
I wasn't like on the smartphone board as soon as they came out. I waited till like an iPhone 4 or something like that. I was late to the game, but I was pretty good with my flip phone and texting with the
I had a
digits. So
BlackBerry.
yeah,
Those
oh,
buttons.
that's good stuff. And so yeah, I would say that we'll see where that in implantables goes, but I would say it's going to be a long time before you see anything besides like proper medical implants.
Yeah.
Also, the FDA is going to get much more stringent on their needs before things are permitted, and that would, even if it's not a drug, if it's surgically implanted, it still would have to go through the FDA, right?
Right.
So all of a
Right.
sudden, if you want to be a commodity purveyor of implantables, you've got a long, expensive path ahead of you. And I think that in itself will really slow the process. You only see some of the bigger companies that can just throw away that overhead.
Yeah. Yeah. And also like what you were discussing earlier and like how these tools that are at your home also help the communities that are socioeconomically challenged, right? Like I could also make a educated assumption that in such communities there might be huge distrust towards institutions. I think we saw that a little bit during the pandemic around vaccines. I mean, rightfully so, right? The distrust. There are abundant examples of why there is distrust.
Yes.
So speaking of like, oh, okay, then we're gonna put something inside your body now to monitor your health. Everybody be like, sign me up.
Yeah.
That's what
I mean,
happened in Europe.
I wouldn't do it.
Yeah,
And
I won't do it either.
I would make one way before I would do it.
Exactly. We're like, we didn't adopt iPhone 4 that fast. We want to really like put something in our bodies. Um, so I could definitely we would have to see the advantages, really like successful case studies all around for a while, I think, even for the to have the conversation of being at scale. But I read this I think it was 2 years ago. Did you know about this like company that created it was an implant for people with vision impairment, and it enabled vision
Mhm.
for
Yeah.
people who were testing it, and then they went out of business. And then people are living with these implants, and they don't even know if they like, is it going to be updated? Like, are they going to lose vision again? Like, speaking of like not understanding or like the entire ecosystem around that technology and not designing that well.
Yeah. I mean, and this is the case with a ton of technologies. If there's not enough adoption up early on, then they dissipate, right?
Yeah.
And there's not necessarily a plan of care after a certain given amount of time. I'm sure there has to be some, according to the FDA, for implantables. I hope so.
I
At
hope
least
so.
like coverage to get them out. If you,
Yeah.
but
Oh,
yeah, I think that the whole ecosystem around it, right? Software updates, firmware updates, getting
yeah.
less clinicians to insert them, right, is no different than say there's all these like certain name brand procedures, I guess you could say, like especially in weight loss and plastic surgery, like you can go through a Sonobella clinic or a LASIK clinic and stuff, right? They have all these sort of branded licensed things. So you would actually have to do a
Yeah.
similar kind of thing, right?
Yeah,
Which
yeah,
means
yeah, yeah.
education. There's a whole infrastructure for it. So the rollout's
Yeah.
going to be slow and it's going to be, up and down, basically. There's going to be a
Yeah.
lot to come up and crash before we can learn the appropriate path, which already is starting to happen, right? So, and vision's that's a big one, right? Then it's honestly of implantables, it's probably one of the uh, safer bets because worst case
Mm,
scenario is you still can't see. Besides, of course, there's the actual procedure itself and risks that go along with that and infection, things of that nature. But as
yeah.
far as quality of life, if it doesn't work out, doesn't go that unchanged, hopefully, pending that they
Yeah.
take good care of during the procedure. So I would say that would be one that um, I wouldn't be surprised if it was an earlier adoption as far as
Yeah.
types.
I think the reason why they failed was more of a poor business management than the technology itself. Like the entire strategy around how to roll out a technology. I think like really understanding then all the dynamics before launching something. I think to your point is really important. All right, so obviously we can talk about all the things that are happening in health tech or not happening in health tech for a day. But to slowly wrap up, for anyone who want to, I mean, maybe come into the health equity space or anywhere, any space where they're pushing boundaries a little bit and going for moonshots, what would be your advice to them?
So most of my advice is on failing. Don't be afraid to fail. Fail fast. Iterate quickly. When you're trying something that is slim chance of working, think about five different things to try and try each of them quickly. Fail fast. You're going to get to your success faster that way. Then I would say think about failure modes. This is something like, say, when they did the pulse oximeter initially was designed, right? They didn't really think about when this would fail. All right. They thought about, oh, this gets us some readings if we do this. When is it going to stop working? If you think
Right.
about when things are not going to work beforehand, you can account for those as much as possible before you move forward, and that helps to build a more equitable system. Um, we can never be perfect and exhaustive, but we can do better.
Mm, I
Yeah,
love that.
don't be afraid to try some stuff. Think about all the things that can go right as well as the things that can go wrong. Try not to get pinned in by the stereotypical way of doing something, or the current way of doing something. I should say, not even stereotypical. Um, that's how we create new sensors, right? Like, oh, what if
Yeah.
that? So experimental.
Coming
Uh,
from the person who's a musician turned health equity genius. Great. So I think there's a lot of validity coming from you.
yeah,
Oh,
no,
well,
I think that if you haven't broken something, you're not trying enough, right? I always tell my students, you should don't be afraid to break something. You should have broken something because you should be trying some crazy stuff.
yeah. Yeah.
So it's one of the things that hinders us the most is anxiety towards trying stuff, right?
Yeah. And more, we see it more even in like the good students because they're used to being good and good at something. So they're even more afraid of failing. So I was a good student. I wish somebody told me like failing is okay. And in fact, you should. Nobody did. But I
Like,
learned it now.
yeah, and even when you've done stuff, right? There's always this like, I got to turn it on eventually. When you're building something, right? Like, all right, got to turn it on. Should I check this again? Just turn it on. All right.
Yeah,
Just hit
yeah,
the
yeah.
on switch and then record some data. All right. Because you can sit there and try and think about all of the simulations and all the theories behind everything you're going to do, but empirical data is what actually matters in the end.
Hmm.
So hit the on switch and stick it on somebody if it's safe.
I love that. That's the name of the episode.
There we go.
Thanks, Alex. This was such a treat. Any projects that are coming up soon that we should be following, we'll add your links on the episode page. And I encourage everyone to follow your work and publications coming from your lab.
Yeah, I mean we have a few works coming out and some of our urinalysis stuff. Kind of keep an eye on the webpage. We'll post on LinkedIn and stuff too whenever we have some publications accepted. If we have some cool study results and things like that. And yeah, so just keep an eye out. I would say that we have it's hard to put a timeline on when things are going to be ready. We have a bunch of deployments about to happen, so not sure. But when we're done, not sure.
All right. Well, that's the beauty of experimentation. Thanks,
Exactly.
Alex.
Thanks, Pinar.
Good time.
Mhm.
And that is this week's episode of What's Wrong with the Podcast. To make sure you never miss an episode, subscribe to our show on Apple Podcasts, Spotify, or any other podcasting platform. You can also subscribe to our YouTube channel. Links can be found in the episode description, and you can also find them on our website, podcast.what'swrongwith.xyz. If you found value in the show, we would appreciate if you could rate us and leave a review, or you can simply tell your friends about us. For more details on our guests, follow us on Instagram and Twitter. Don't forget to join us next week. Thank you for listening.